imperatives for implementing pediatric-specific social drivers of health, screening and intervention, with particular focus on the ethical considerations that we lent to that process. We also will review the actionable tools and workflows that we incorporated that were specific to the pediatric population. And again, specific considerations that we lent to the decision-making on that process. We will identify key components of a successful multidisciplinary workflow that optimized our pediatric social driver of health screening, and how we incorporated multiple levels of care, inpatient clinic, community-based settings, and then also speak to best practices for building partnerships that are really necessary to optimize this work. I will also reveal that none of the three of us have any disclosures regarding commercial relationships. And with that, I will hand it over to Dr. Mills to launch the conversation.
Thank you so much, Mary. And my my video, I keep trying to turn it on, and it says that that the host is disabled my video. So I am here, and I do have a face, but oh, okay. Now I gotta says that the host is letting me. There we go. Okay. So anyway, it's great to be here. It's an honor to be here. And thank you, first of all, thank you so much for everything you do. I know as a formerly practicing pediatrician and one who's now works mostly in administration, that I am deeply grateful for all the work that case managers do. Your work is really the front lines, tireless work that makes a huge difference in children and their families' lives. So thank you so much for everything you do. So at Maine Health, Jenny and Mary and I work together and as a team, and it's been a wonderful journey that we just want to share a little bit of our journey with you. And at Maine Health, this is our vision. So you can see here, so our vision is a bit unusual because it's about working together so our communities are the healthiest in America. So we take that very seriously. So the center that I oversee, the Center for Health Improvement, is actually works in community health, but also at that nexus between public health and healthcare. Next slide, please. Or do I move it to? Okay, so this is just for those of you who aren't in Maine. This is where our hospitals are located. So you can see that they're mostly in the southern and western part of the state and up the coast. We do cover about 85% of the population because most of the population in Maine is in that southern half of the state. And we have a flagship hospital, Maine Medical Center in Portland, a psychiatric hospital, Spring Harbor, and then also a number of community hospitals, all of which are in rural Maine. Next slide, please. And you can see here we are an integrated health system with, as I mentioned, the Center for Health Improvement, but also just a wide range of activities, both working throughout our communities, where we provide a lot of the public health essential services in our communities. And then we obviously provide lots of healthcare, both in our hospitals as well as our outpatient settings. And, when we started this journey 2 or 3 years ago, one of the things that was that people asked, especially some of our case managers, said, well, what is the ethics really of asking these questions about social drivers of health, or what we also call health-related social needs? So what are the ethics of asking about people's housing stability, food insecurity, transportation difficulties, challenges paying for utilities, and intimate partner violence, if we can't do something about them in a significant way? If somebody's unhoused and we can't really solve that for them, is it really how ethical it is for us to ask that? And we had some very interesting discussions on that very question. And what we found was that CMS, Centers for Medicare and Medicaid, did conduct a lot of studies on the accountable care communities in the late 20-teens, early 2020s, and on addressing screening in hospital settings and addressing social drivers of health or health-related social needs in those settings. And what they found was that the care that our patients receive is actually better, even if we ask the questions and we can't do anything significantly about the actual health-related social needs. So as an example, what they found in these studies and across multiple health systems, hospitals around the country, was that if you ask about transportation, even if you can't provide the patient transportation, the care that the discharge planning, the care that we're providing is actually more appropriate, knowing that that patient doesn't have, and that family does not have easy access to transportation. So, so instead of prescribing 3 physical therapy appointments a week, half an hour's drive, there may be something like in-home physical therapy once a week, something like that. So, to accommodate that. Next slide, please. And so this is so the center that I direct. We were asked to lead this effort, but as you'll see, we're really very much not the leader. It's really it's a very much of an interprofessional collaborative. But we do, in terms of what is the Center of Health Improvement, we are a center of about 305 care team members, and we work in that nexus, as I mentioned, between public health and healthcare, particularly because throughout New England, we really don't have a history of local public health departments spread out across our states, particularly in rural areas. So we provide a lot of the non-regulatory public health functions, and particularly our rural areas of the state. Next slide, please. And then this is a little bit more on the main health model of the Center for Health Improvement. So we have a hub located at organizationally at corporate services, where we provide have a grants office. We provide grants writing and support, communication support, strategic planning, and data analytics, which you'll see in a bit. I think Mary's going to go over some of the data analytics that we have available to us. Next slide, please. And then the spokes, so this hub and spokes model that the Center for Health Improvement has, the spokes are our local hospitals. And in each one of them, we have a community health director with a public health background that reports up through to me. And they work right in that nexus between public health and healthcare. So they work with our clinicians and our clinical care teams, such as our care managers, case managers, and they also work out in communities. And they have a lot of relationships with communities as well. And are really key to helping to move many of these efforts forward in partnership, really, with people like Mary and Jenny. Next slide, please. And if you could just click through to get to the diagram, sorry. So one of the things, that's been very exciting to me is I'm a pediatrician, originally practiced in rural Maine, in my hometown of Farmington years ago. And but also been in public health. I'm a medical epidemiologist, and I've been in public health for almost 30 years, 29 years. So what's exciting to me is this journey that we've been on, Mary, Jenny, and I, and many others have been on at Maine Health, to screen all of our patients for health-related social needs and addressing social drivers of health, has really been bringing together public health, healthcare, and case management. I have a cousin who works in Denmark as a social worker for people who were discharged from the prison system. And years ago, I remember like 30 years ago, I asked her one time, they'd come over here every summer, and I said, oh, so you work as a social worker, like, how do you work with the healthcare system, and how do you interact with the public health system? And she said, well, Dora, it's kind of interesting because in Denmark, they're all the same system. They're not social work, public health, case management, social work, and case management, healthcare, and public health are all the same system. Now, I'm not suggesting that they have to be all the same system here, but I think this work has really brought together in a very interprofessional way a lot of us from these different disciplines, and figuring out how do we work together, how do we learn from and with and about each other. Next slide, please. Excuse me. And I think, yes, and that's some of when we started on this journey too, we also had to look at the data. So you probably have very similar data in your own states if you're not from Maine, but we did promote these data to our interprofessional team, because we realized we really needed to start with the why. Why are we screening people for these 5 major health-related social needs? And as you can see, some of those reasons right there. Now, with adults, we screen them for intimate partner violence, and with children, we deleted that, and instead we screen the younger ones or developmentally appropriate ones for diaper security. Should mention that we started on this road as a part of our strategic plan back in 2022, and it was before the CMS requirements about screening hospitalized patients came about. So we decided we were going to do this before we knew about the requirements. Now the requirements are for screening adults in inpatient settings, but we also decided that we needed to screen our children as well, who are inpatients, and then increasingly we're moving in outpatient settings as well. And even if the CMS requirements go away, which they might because they're proposing that, we feel our experience the last couple of years has really shown us how important this screening is. And so we're going to continue to do it regardless of CMS requirements. And next slide. So we also started out by realizing, while the original goal was to screen our patients and their families for health-related social needs, that we kind of felt like as a team that we would be sort of putting a lot of Band-Aids on things if we just had that as a goal, to screen and try to link them to resources. So we also developed the second goal, a little bit more aspirational, that we would somehow try to use these data, the screening data, the screen positive data, and working with community-based organizations, partnering with others to figure out, and policymakers, to figure out how can we address the underlying social drivers of health. So for instance, if we're screening for food insecurity, how can we address the underlying issues of poverty? And I'll give you a short story. Is the way we started down that road was when we started collecting enough screening data to share, we started a series of community conversations. And of course, since this is post-acute phase of the pandemic, we do this by Zoom now. So we have about 150 to 200 people and organizations whom we meet with about every 6 weeks. We share the data, and these days we share usually a theme data, like we'll have a meeting on just transportation, and we share mostly transportation data with a deep dive on transportation by geography, by race, ethnicity, age, etc. So one time when we were presenting the data a few months ago, someone from one of the ethnic community-based organizations serving mostly asylum seekers said, I know that the screen positive rate for those screening positive for a difficulty paying utilities is kind of low, but we actually experience it in our communities because the power companies, there are only 2 power companies in Maine, but when you don't have a credit history, so you're a new immigrant to the country, or you're a young person starting out, some of us who have young adult kids don't have much of a credit history, that when you then go to get an electricity account from one of the 2 power companies, because you're renting a place or something like that, they can charge you a lot for a deposit, $600 to $1,200, $2,000, we heard, for just a deposit because they didn't have a credit history. So when that came to my attention, I actually called the public advocate for the state, the public advocate for the Public Utilities Commission, talked to him. He didn't know about this, and then looked it up and realized, there was nothing allowing them from charging quite a bit of money. So he introduced a bill in the legislature that is now under consideration to cap how much power companies can charge for a deposit even when you don't have a credit history. So a small story, but it was kind of interesting. And I think as a health system, we have a much better we're a much better place to try to do something about these kinds of issues. And so just sharing that data has even resulted in some movement so far, even. And next slide. And I think, Mary, are we going to take a note on this?
So We just wanted to call forward one of the principles that this whole conversation is addressing, and building on what Dora just said. I believe that there are times when we don't always acknowledge and believe in the strength of one, right? In the example that Dora just gave, every single assessment for social drivers of health that we do that nets a positive screen creates a pool of information that then is, it's a public health principle. You start with an individual, it grows to the community for intervention and becomes a policy. Dora's example did exactly that. So it's a great example of the integrity and the fidelity ethical principle that we are advancing this. We're not walking away from the challenges, we're acknowledging them and working to assure that the screening and the interventions carry forward on behalf of the patients. So that's a great story, Dora. Thank you.
Thank you. Next slide. So this is basically has been our framework of how we've addressed this. And again, this is an interprofessional team that came together 2.5 years ago or so. Mary and Jenny were part of that. And, I really didn't know Mary and Jenny before that. So it's been a great opportunity for a group of us. And you'll see, Mary will show you or Jenny, the broader team. And it's like people from IT I never would have been able to meet and to get to know. So we've all really done a lot of work learning from, with, and about each other and figuring out how to best to tackle this. We also provided, this was case management's idea, as you might not too surprised that we needed a trauma-informed approach. So we did a online learning module for all of our team members who do the screening. And then we've also had an approach of data sharing, obviously non-identified data, but as you'll see later. So this has been sort of 3 major strategies and kind of a bit of some principles that we've used moving forward. So I'm going to toss the baton over to Mary and Jenny.
Okay, thank you. So continuing on with the strategy that we used, it was a 5-point implementation strategy. And it launched with the interprofessional team, which Dora has referenced repeatedly. Jenny's going to talk about examples in detail. And I will say it was a tremendous opportunity to really break down silos and help and really kind of embrace that caring philosophy that everyone really holds near and dear to their heart as we advance this work. Screening strategies, we talked a lot about building on what Dora introduced, not just screening, but screening and identifying intervention strategies. And formalizing referral systems, making sure the referral systems were systems that could be accessed by our clients and members and patients, not so onerous an access process that no one could ever break through. And then using the data dashboard, which gathers information from those preceding processes to inform and help us to create next steps. All of this together works because everyone is fully invested. That trust and partnership in this for the greater good is key, and it's pervasive through the entire team. So has really led to a really effective implementation. Next slide. Jenny, this is you.
All right. So at Maine Health, as we've mentioned already, we have a group dedicated to supporting this work across our health system. This group consists of partners from informatics, from nursing and social work leadership, community health improvement, and patient engagement and communications. As we've mentioned, the multidisciplinary team approach really lets us focus on our different lenses and what we can bring to the social drivers of health conversation and the impact that it can make to our patients and families.
So continuing on with additional principles, placing the public interest above our own at all times. So always looking at the greater good. When we're at an interesting point in healthcare where it has become increasingly evident that our clinical care is exceptional, but our patients don't always get better still. So these social drivers of health are absolutely influencing how our patients are set up for success, whether they're adults or pediatrics, but pediatrics in particular, because our children rely on their parents. So making sure that we are building systems that have their needs front and center and then always maintaining the integrity and fidelity of what we have committed to. Next slide.
Okay. So this here shows the workflow that we have implemented across Maine Health for social drivers of health screening and intervention. So the admitting nurse completes the initial SDoH screen. Should there be a positive screen in any domain, the patient is looking for support around that, we look to care management for intervention and recommendations. We worked with our Epic partners to create a streamlined process within Epic to auto-refer consults, whether it be to case management or social work, depending on our institution, to initiate the consult for us to see the patients. Once the consult is in some hospitals, the nurse care manager can assess and make recommendations for this patient or family. And in Maine Health in Portland and Biddeford, a social worker completes a full psychosocial assessment for intervention and recommendations.
So I will say on this slide too, Jenny, if I could comment, we did spend a fair amount of time talking about how was the fail-safe way to complete this assessment, right? And the reality in healthcare, especially in an inpatient setting, and that is the rule on this SDoH screening. It is inpatients. So it is during a hospitalization. So, and a lot of the admission work does flow to the admitting nurse. So there was a lot of conversation about whether or not that really was the best point of entry. In our system, our care management department covers 7 days a week, but we cover 8 hours a day. So what we landed on was nursing as the original point of assessment, because we would, at the care management department, would always have gaps. We would always lose patients in that process. So everyone agreed that that was our ethical obligation to make sure that we had the opportunity to see every patient. Understanding that at the point of admission, every patient is not ready or in a situation where they could answer these questions, whether it's the child's parents or an adult. And that's where case management, the RN care manager, is set up as the safety net. So we can all see on our Epic screens when the last time they were answered was. So if the admitting nurse hasn't had the opportunity to complete the screening, it will defer to the RN care manager as their assessment. And then, as Jenny described, the positive responses flow automatically to our social work partners for assessment and intervention. So here's a look at some of the data findings that we have. This is pediatrics only. From January 1 of 25 to April 30th of 25, the two hospitals listed in the top box are Maine Medical Center Portland, that's our flagship hospital. And we also included behavioral health at Spring Harbor. That is our inpatient behavioral health hospital. So definitely variation in the total numbers of screenings, but it's interesting to look at the positivity rate. 12% with our behavioral health population and 17% with our full pediatric population at Barbara Bush Children's Hospital. So having that perception of social driver of health impact actualized into a number is very, very beneficial. So as we look at the data to the left, we didn't really see variation specific to gender. Everything looked pretty similar there. There also wasn't significant variation in the pediatric age brackets, the 0 to 2 versus 13 to 17. Not surprising, there was significant variation when you look at payer. Those who rely on Maine Care, which is Maine's Medicaid population or Medicaid payer, absolutely had more positivity in the social drivers of health realm. Moving over to the right for race, our Black and African American population far exceed the general populations, followed by our Asian population. We have a fairly high immigrant population here, and They may declare Black or African American, or they may declare other. The other population is fairly small as well. So again, not surprising, but helping to really clarify what the presentation of the population is. And then the distinction between English speakers and non-English speakers. Within the hospital, we have language support. We have interpreters on site and available online. What we found as we did dig down in this on the adult population, so I believe the same would be applicable to our pediatric population, is it's challenging to have interpreters available on demand. And sometimes using the online is not as favorable. So the number of screenings is less, but that population is challenged with advocating for themselves in general. Next slide. So this slide shows some increasing numbers. It shows an 8% positivity rate as opposed to the 17% positivity rate on the previous screen. 17% is complete screens. So looking at all 5 drivers ended up at 17%, but looking at individual drivers, the overall volume is higher when you split it apart. So that is the cause of the variation there. But you can see on the graphic, what are the food insecurity on the bottom left is clearly was screened high and is fairly high on positivity, as is housing instability in our population. That is absolutely the lived experience in Maine. But you can see kind of where all of them fall forward. Next slide, please. And we wanted to put forward a comparison to the adult population, so you could see when you do isolate pediatrics, what variation are we seeing, and what was the driver really to advance the official screening for pediatrics. So again, it's the same time frame, January 1 to April 30th. We included all of our hospitals. At the top is Spring Harbor, and it does this positivity of 52% does include the adults. The slide that showed where these hospitals are throughout Maine gave you kind of an indication of how rural a lot of our hospitals are. The second one on the row, Maine Health, Maine Medical Center, Biddeford, and Sanford, has a 19% positivity rate. It is in southern Maine, but Sanford, our Sanford location, is a behavioral health hospital. So likely some influence there of the behavioral health component that was driving the high positivity rate at Spring Harbor. Our own hospital where Jenny and I work is Maine Medical Center, Portland, third from the bottom. It is our flagship hospital, so certainly has the highest number of patients who have been screened. It's showing a 14% positivity rate there. So there's absolutely need, there's absolutely demand for focus on the social drivers of health. As Dora did point out in this screening for adults, it did include intimate partner violence, not diaper security. So that is the one variation that we saw. There was some variability among age groups, slight variability in male, female, but the payer source certainly was consistent with Medicaid or no coverage. Also, the Black and African American population bubbled to the top again on this based on the numbers. There is a higher number with Native Hawaiian and other Pacific Islanders. It is only 5 patients though that were screened. And again, the same issue that we have with non-English speakers and making sure that we are sensitive to the needs of the population where English is not the primary spoken language. So absolutely a need that we have overall. Next slide.
And I just want to mention too, the screening count, right? So we've been doing, this is just January 1st to April 30th. You know, we have screened at Maine Health over 13,000 patients to assess their social drivers of health. So normalizing that conversation has been, you know, pretty incredible.
Mm-hmm.
Okay, so we've been talking a lot about the case management impact and how we as nurse case managers or social work case managers really tie into this discussion. As we've mentioned already, the nurse care managers are the safety net for screening. So if the bedside nurse is not able to complete that initial screen for whatever reason, the nurse care manager is able to jump in to assess the drivers that either were not answered or complete the entire screen. As a valued member of the interdisciplinary team, the nurse care managers are able to work with both patients and families, as well as the team, to talk about the impact of the social drivers for health and the discharge plan and coordination that can be impacted by that. As Dr. Mills said, you know, if therapy is being recommended outpatient and they have to travel an hour each way to get to a therapy appointment, that's not going to work, and therefore that discharge plan is not going to be a plan that works best for the patient. So working with the care team to advocate for the impact of these drivers and the patients and families has been really instrumental. Of course, as case managers, we advocate for our patients. We rely on our standards of practice and the case management code of professional conduct. As social work case managers here in Portland and in Biddeford, as I mentioned previously, we complete full psychosocial assessments and screenings to identify biopsychosocial needs, including the social drivers of health. We don't just ask about positive screens. If we know someone tested or was positive for food insecurity, that doesn't mean that's only what we're going to ask them. We're going to ask them all of the drivers of health. We're also going to assess, you know, any mental health or supports in the home to make sure we're getting a picture of this patient or this family's situation so we can best support them. We, as always, are assessing for safety. We're assessing the safety of our patients and their families. We're assessing child safety and any other dependent adults. We refer and engage with community partners based on the patient's and family's needs and wants. And like nurse case managers, we continue to advocate and rely on our code of ethics and our standards of practice to guide our decision making. So when a social work case manager is not available, you know, what would we recommend that you do? Know your systems, know your geographical area, know what's available around you. There's local resources available to many of us through 211, utilizing that and asking questions. Call a subject matter expert, call a social worker in another hospital to really get to know what's around so that you're best able to support your patients. Working with your care team, get to understand what the impact can be on the driver of health to this patient and family. Going back to transportation, if this patient is needing weight checks and they're not able to get there, what is the impact of that? As we know, failure to thrive would be an impact and how that can be detrimental long-term. And as always, relying back to your standards of practice and your code of ethics, as we all do every day, really as a guide to guide us through this process. All right. So here in Maine Health, we are very fortunate that we do have a pretty robust system around us that supports continued referrals for positive SDoH screens. We have a program called the Patient Assistance Line, which is managed by our Access to Care program through the Center for Health Improvement. This is a line that's staffed Monday through Friday with case managers that are able to provide referrals, continued referrals, and support both while they're inpatient as well as when they're outpatient. We are also really lucky that we have community health workers in part of our state. Those community health workers are able to meet patients in a hospital setting and back at home to continue sending referrals and recommendations for patients maybe with English as a second language or additional needs. We are fortunate that we have emergency food bags here at Maine Health that we are able to distribute for patients that report food insecurity. We can send them with some food to leave the hospital with. We have an online referral system called Find Help that we are able to upload food pantry lists and community resources in. So we're able to discharge patients with a list of organizations that are able to offer continued support when they leave the hospital in hand. We have a diaper bank here in Portland that families can access diapers twice a month. So I really feel like for a small, pretty rural state, we do have a robust social support system. While there's certainly not solutions for everything, I do feel like we as a system have really worked together to try and do the best we can in support of our patients. All right, Dr. Mills.
Trying to grab the audio button. So yeah, it was so anyway, as I mentioned earlier, that we've been having these communications or these conversations with community organizations, or what we call CBOs, and they include particularly the CAP agencies, the people in education, people at the state level, statewide organizations that work on housing and transportation and the like, the AAAs, the area agencies on aging, many others, and in the greater Portland area, a lot of ethnic community-based organizations as well, and other healthcare providers, federally qualified health centers, rural health clinics, and even some few private practices. So that's those conversations about sharing our data. And as I mentioned at the beginning, it was just sharing the data we had, all the data, but then we realized over time, it was much more fruitful to have a theme-based conversation. So one, meeting on transportation, and a meeting on the data with a deeper dive on race and ethnicity, and we had one on housing, for instance. So and so we've been inviting particularly those, for instance, in working on housing statewide, to those specific conversations. And the interesting thing, we didn't know where that was going to go. We just started those conversations, and they're a lot easier to do these days because you can invite people to a Zoom call. But people have been very, very interested in the data, which we did not, I think, fully anticipate. And I think one reason is that the data is viewed as very trustworthy. So what I mean by that is we do have ALICE data that is generated by the United Ways, census data, the Feeding America data. So there's a lot of data out there showing the levels of different ways of looking at poverty across our state and counties across the country. But I think they're usually formula based. So they're taking some kind of basic data like census data and then applying a formula to it to get estimates, to obtain estimates in each county, for instance, of how many people are living below the poverty line or struggling to address their basic needs. This is data that healthcare systems are asking patients, so it seems to be much more real to them, that these are us asking patients, there's 12 questions for the 5 health-related social needs, but basically questions about housing and security, for instance. And so I think it's got that trust level somehow, and a real reality to it, that it's not just based on estimates, but it's actually real people answering these questions. So it's been helpful to share the data. I know others are using it too in their work, but we've also seen like it has also helped us to build trust amongst a lot of organizations, that, as I mentioned earlier, those organizations that we've got relationships with them, particularly people like Mary and Jenny, but we've been growing those relationships more interprofessionally, and also through some of these surprises of sharing the stories. We've been asking people, do these data match the stories in your own work? And then sometimes most of the time they say yes, but this is very helpful data. But sometimes they say, well, no, and there's a little reason for that. So as an example, the lower rates of older people screening positive, we think that's because we have a higher proportion of inpatients who are older, who are from long-term care facilities. So they're going to say, yeah, my housing's okay, my food is okay. So anyway, so that's it's been an interesting journey to help us. We didn't know where we were going to be going when we started, and here we are 2 or so years later, and we're actually been growing a lot of relationships internally, interprofessional relationships internally at Maine Health, but also with our community partners. And I think that has been one of the most exciting places. And I don't know where it's going to go, continue to go, but it's very exciting to me to see these disciplines come together and really working more closely together. So I'm going to throw the baton over to Mary, and I think there is a question too. Was there a national center? Yeah, this is an organization, CHI, or Center for Health Improvement, is just within Maine Health. It's a department at Maine Health that has about 300 people, and we work across our system, and we do community health work, but we work also with clinical sites. So we kind of work in that nexus between public health and healthcare. That's what we say. So Mary, if you want to.
Kind of another question or observation, something that we certainly struggle with. You alluded to earlier in the presentation, Dora, if you would like to comment, that the changing face of healthcare, that's like that comes out of everyone's mouth frequently when you talk about what's going to happen tomorrow, and we don't necessarily know for sure. But you did identify that this is does look like it is not going to be continued as a requirement with CMS. If you want to just talk about that specifically and what you see in terms of healthcare and continued opportunities, I think that's important.
Yeah, no, we've been very committed at Maine Health to continue to do the screening because we're seeing the impacts of it. We're seeing that in our frontline, we wouldn't just sit here in administration and say, oh, we're going to continue to do it. But actually, a lot of our frontline care team members are saying, this is important work. I mean, it's been really heartwarming to hear them say, and people like Mary and Jenny and others who work with them have on the front line saying, this is important work. We're learning a lot about our patients we didn't know so much before. They used to ask, I mean, but if there was a reason to ask, and now they're asking everybody, and the answers are oftentimes surprising. And then as we're building out the resources, the partnerships with community-based organizations so that we can improve the way that we're addressing these health-related social needs, those multiple resources that Mary mentioned. We're also using the electronic health record, EPIC, excuse me, to assess the efficacy of each of those types of referrals. Realizing we're not going to solve everybody's major health, housing issues, for instance, overnight, but it does help. We've found out, learned through the EPIC analysis that with the referrals to community health workers, that tends to be who are out in the community setting, that tends to be a very, very effective way. It does reduce future emergency room visits as well as readmissions.
Mm-hmm. To piggyback off of that, as a social worker or as a case manager, like we want to help patients and families solve problems, right? Of course. And there are a lot of problems that we can't solve, but by having this discussion and normalizing the discussion and trying to be proactive in referrals to housing or community case managers or starting applications, we can potentially change the trajectory of the next time they're needing care, or we can help connect them with a PCP when they don't have one, so they're not utilizing our emergency department. So even when it feels like we can't solve the problem necessarily, we can still make meaningful impacts.
Absolutely. It doesn't have to be a formal program to be impactful. So always remember our role as advocates, as case managers. And even if you don't have necessarily the structure of a formal program around you anymore, the program does informally still exist. So we shouldn't throw the baby out with the bathwater and continue the elements that we can, even if CMS doesn't require it of us, for all of the favorable reasons that we were able to demonstrate. So,
and Evelyn has a question. Have you found the outside resources have truly closed the loop? Yes. So they, for the most part, what we can tell is that they do, and Mary, Jenny comment on this, but I think they do, follow up. I mean, we work closely with, it's a small state, so we work closely with, we make a referral to a CAP agency. They follow up. What we don't always know is the full circle. Like we don't always get the information back from them. Find Help does have a way to do that, but it's also, it's time consuming for the community-based organizations, such as a CAP agency, to, fill that out and send it back to us. So we don't always get the full circle, but we at least get the, the knowing that patients were referred and the community-based organization did take on something. But Mary and Jenny, do you have anything else to add to that?
No, I think you touched on it perfectly.
I just have a second question to that though, but do you think that it would be important to have that full circle? Do you think it would make a difference?
It would, I think it would be great. But we, we're not Denmark, so we're not all one system. So with all the HIPAA laws, it's a little challenging for us to give and receive information from an outside organization like that does pertain to patients. But also what we're looking at though is are things like the frequency of emergency room visits and readmissions. And so we can see like, oh, if we refer them to these groups over here, the community health workers, CAP agencies, like we're seeing some reduction in compared to their prior to referral. So we are able to document some ongoing, and we don't have enough of that data yet. It's not robust enough for us to share, but we are looking at it. And the community health worker data are fairly easy to share, but we've seen those who receive a community health worker referral, we're seeing a 90% reduction in readmissions and emergency department visits after the community health referral compared to before. So that's it's been very striking and is helping us make the argument that we need more funding for more community health workers.
Yeah, I'm sure that's important information for Evelyn in her new role. Yeah.
And I think too, it depends on where you work, right? In what setting you're a case manager. For an inpatient case manager, we're trying to connect kind of the dotted line from the admission to what's next. How are they going to be supported once they leave? If you're working in a more outpatient setting, you might see that bigger full circle picture.
Absolutely. Any more questions from the group?
Well, thank you again for everything everybody does. Your very important work, and we're
Odor, we've lost you. So you're starting to get thank yous in the chat, and I really want to thank all the presenters and the committee for great work. You're getting some claps too, rising up, and it really was an awesome presentation, and I'm so thankful for you because this was our first special interest group, and you met more than our expectations. It was fantastic. Thank you so much.
Thank you so much. Anyway, it was an honor to join you. So thank you.
Thank you. So I have